and our scientific advisor and South Zone VP 2024, Dr. Singarvel sir. So, and our other office bearers, Joint Secretaries Dr. Sudhagar and Jayavardhana, Editor Dr. Sridevi, and Central as well as State EB members. On behalf of IAPTNSA, welcome one and all. And I welcome today's program convener, Dr. Aswath, and who has done tremendous work past almost 8 months. And because of IAPTNC, really appreciate Dr. Aswath's work. And I welcome today's resource persons, Dr. Aguila Ayya, who's a well-known endocrinologist in India, and she was chairperson of Endocrine Society of India also. And on behalf of IAPTNC, welcome, madam. And she will do her job
Thank
better.
you so much.
Yeah, thank you. And I welcome Dr. Akansha Parikh, and she's a well-known endocrinologist from Mumbai. On behalf of IAPTNC, I welcome and you and also your son also, I think your son also there. And again, on behalf of IAPTNC, welcome. And it's endocrine problems, I think we can, that's why you have to start our documentation, that means growth and development from birth onwards, and early recognition, definitely that comorbid conditions, and I think you can reduce it. I think Dr. Agila Iyavo, Dr. Akansha, they will talk about that one. And once again, on behalf of IAPTNC, welcome on. Thank you.
Thank you, sir. Now I request the Vice President of IAP TNSC, Dr. Gopal Subramaniam, sir, to say a few words.
Thank you, Dr. Thiru. Respected President Dr. Rajendra sir, Secretary Narmada, and Treasurer Rajkumar, past President Balashankar sir, and incoming President Somasundaram sir, and our past 2024 Vice President of South Zone, Dr. Singarvel sir. Thank you. This program has been very much hit among all the pediatricians and practitioners all over India. And thank you, Dr. Ashwath, for being the lead role in this particular program. And I welcome all the dignitaries and the presenters here. On behalf of IAPTNSC, I welcome you all. Thank you.
Thank you. Now I request the program convener, Dr. Ashwath sir, to take over the stage and conduct the proceedings.
Good evening, one and all. It is the 7th edition of the P4 series. It is a brainchild of Dr. KR, who has been at the forefront of leading academics, and especially electronic media has never had it so good. Under sir's guidance and ably assisted by Dr. Thiru and his dedicated team of APTNSC office bearers, ever since COVID broke out, we have seen a spurt in academic activity. So we are extremely happy to invite our panelists, both Dr. Akhila and Dr. Akansha Parikh. One is a superstar in her own right, and the other one is a rising superstar. And probably another superstar is the budding son of Dr. Akansha, has also come in as the unannounced expert. So he will be a pediatric witness cum coordinator, I suppose. So both of them have been extremely lucky, our panelists today, in that they've shared a very, very illustrious guru. They are both students of Dr. Paini Raghupati, and he's, as we all know, the teacher of teachers, and has been instrumental in mentoring and creating a protege of brilliant and illustrious students. So we have no doubt in our minds that Dr. Akhila, who is a graduate of our own Coimbatore Medical College, followed by DCH from the prestigious ICH, and then she went on to do her PhD and fellowship in New Zealand, and has been championing the cause of pediatric endocrinology in South India for the past so many years. We also welcome on board Dr. Akansha Parikh, who is, I'm proud to say, very many years my junior at KEM Bombay, who's also been mentored by Dr. Raghupati, and she trained with him at Indira Gandhi Institute at Bangalore. Both of them have sufficient number of papers and publications to their credit. So we have no doubt in our minds that we'll have a wonderful 1.5 hours of very, very meaningful and practical interactions, because the main target audience of this entire P4 series is a practicing pediatrician. So I'm sure they will have lots of practical wisdom to share with the participants. So without taking much more time, I will invite Dr. Akhila to have a half-an-hour presentation on practical disorders of pediatric hyper and hypothyroidism. and then we'll have about an hour of deliberations and other allied topics. Thank you. Over to you, Dr. Akhila.
Thank you so much, Ashwath. Thank you, Dr. Rajendran, for this huge amount of initiative you've taken over the last several years in improving pediatric education in Tamil Nadu and South India. And I'm deeply thankful to Dr. Ashwath and for taking this initiative. And I'm a little bit worried because Ashwath is going to be the convener. What difficult questions he's going to ask me, something which is going at the back of my mind. Thank you so much, Ashwath, and thanks, Akanksha, for accepting that invite at such a short notice. She's a wonderful person, and I'm sure Vedant is also going to join and contribute his own to this meeting. Welcome to Vedant also, who's Akanksha's son. And then I'm thankful to Dr. Thirumurugan, Dr. Srinivasan sir for making it so much, and he's been actually asking when is it starting and all that. I'm hoping to see I actually do justice to this. So it's going to be a very simple presentation focusing on practical aspects of hypothyroidism for practicing pediatricians. So all of us know hypothyroidism could be due to structural or functional dysfunction, or it could have its onset at early life, a little bit later or very late. It could be there from birth or it could happen a bit later. If you have such an obvious picture, which I inherited from Professor Ravi Kumar, and I think as Ashwath mentioned, Dr. Raghupati is always at the back of all my presentations, and I owe to him for what I'm doing today and where I am today. So this is from Dr. Ravi Kumar. So it is so obvious this newborn children have a huge goiter. So here you don't have any doubt. You know that the thyroid has an issue in these children. When you have clinical pictures like this, which is so very obvious, like even a third year clinical medicine student can pick up with all obvious clinical features, I think there is no doubt about the diagnosis. These are typical clinical features of hypothyroidism, which include reduction in activity, poor feeding, large fontanelles. And I should make a specific mention of the posterior fontanelle. If the posterior fontanelle has not closed by 6 weeks, please recheck your thyroid functions. Because an ENT surgeon had picked up his child's hypothyroidism just by palpating the posterior fontanelle, though the initial screening was normal. Hypotonia, noisy breathing, poor growth, delayed milestones, hoarse cry, coarse facies, dry, scaly skin, hypothermia, delayed and prolonged passage of meconium, reduced stooling, and constipation. Constipation is just not the number of stools they pass in a week or so. It is also to do with the consistency of the stools, which I think several times we have even listened to Dr. Ashwath, Dr. Somasundram talk about it in previous meetings also. Prolonged physiological jaundice, and then protuberant abdomen and umbilical hernia. These are obvious clinical features, but you cannot wait for these clinical features to happen before you diagnose congenital hypothyroidism. All of us know the later you diagnose, the worse the clinical outcomes are pertaining to the development, both neurologically and for growth. So it is important to diagnose congenital hypothyroidism as early as possible to have the best long-term neurodevelopmental outcomes and a fantastic future life. Okay, see, these are 3 children. I think all of us have always concentrated only on the protrusion of tongue. So the first boy has been checked for thyroid functions 3 times. The second one has been checked for 3 times because he also had a slightly prominent umbilicus. And the third child had not been checked because he looked otherwise normal. If the neonatal screening had been done, both these children had a TSH of less than 20. They would have had a TSH of less than 20 at birth. And this child would have had a TSH of more than 20 at birth. I think though Akanksha may not understand, there's a very famous song in Tamil. Kannai nambade, unnai ematrum, nee kaadum thotram, unnai illadadu. அறிவை நீ நம்பு உள்ளம் தெளிவாகும் அடையாளம் காட்டும் பொய்யே சொல்லாதது. So I think finally it boils down to our clinical acumen and clinical experience which helps you. So we'll go one by one. So we have just a minute, I just minimize this. So we have a full-term baby who was born by normal delivery. whose cord blood TSH is more than 150. I think there's no doubt that this child has congenital hypothyroidism. This child has no clinical features of hypothyroidism. At birth, I think almost none of those children would have features of congenital hypothyroidism, except for those which have those prominent goiters. What should we do? So if the TSH is more than 40 in the cord blood sample, you will send a confirmatory venous sample for TSH and total T4 or free T4 after 72 hours. Though some say 48 to 72 hours, but there can be still a bit of overlap between 48 to 72 hours. Once the child is exposed to the outside environment, there will be a TSH surge post-birth. So this is a newborn thyroid screening done on a cord blood. So this is prior to being exposed to the cold and the effect of cold acting on the thyroid axis. You will image for etiological diagnosis if possible, and then start thyroxine as soon as possible. So this will be, you would have started treatment at 3 days of life in this child. When you do a nuclear synthi scan, this is how it looks. This is a child whose first picture is a normal synthi scan on technetium. Whereas the next one shows no presence of thyroid gland on a synthi scan. The synthi scan is preferred over ultrasound in certain centers or most centers of the world because ectopic is difficult to pick up on a ultrasound of a thyroid. But there are also some centers which advocate just an ultrasound. If you don't have the presence of thyroid gland in its normal position, that also signifies that this is a structural abnormality of the thyroid gland. So thyroxine dose for congenital hypothyroidism. Treatment should be initiated before 14 days of life for the best long-term outcomes. High-dose thyroxine, which is 10 to 15, or some books say 9 to 15 mics per kg per day, which again has the best long-term outcomes. There is rapid normalization of TSH, and this leads to better neurodevelopment in later life. The further thyroxine doses are adjusted based on TFT. So you will start at 10 to 15 mics per kg per day. You will repeat the thyroid functions in 10 to 14 days based on the level of TSH at diagnosis, and then try to come down on the dose as fast as possible because you don't want them to have the effects of hyperthyroidism over a longer period of time. Follow up T4 or free T4 after 2 weeks. If you think TSH is a bit of an issue, if the cost is an issue, or you can do T4, but you will repeat T4 or free T4 and TSH after 4 weeks, but because TSH will anyway take time to come down. If the T4 and free T4 have reached the upper half of the normal range, then this child is actually doing well. Target T4 and FT4 always in the upper half of the range, reference range by 2 weeks. Why am I talking about this reference range? Each lab has its own cutoff based on their minus to plus 3 standard deviation as their normal value in a huge cohort of the patients that they see in their hospital. So the methodology of the testing can be different, and free T4 is not always very reliable because equilibrium analysis is the best way to measure free T4, which is not possible. So there are a lot of fallacies. Actually, T4 is a much better or easier analyte to be measured. So if you have T4, only when you have compromise or difficulty in getting a good T4, you can go for free T4 because some of the labs may have difficulty in doing a good T4. So that's why I always do T4 and free T4 to have a quality control against each other. TSH should reach the lower half of reference range by 4 weeks. How frequently will you do thyroid function tests? If the TSH is very high at diagnosis, and if it is athyrosis of a significant dysharmonogenesis or a very severe hypothyroidism at onset, you will do it every month until 6 months of age. And then 2 to 4 months from 6 to 36 months, depending on the thyroid functions and the values that the children have achieved along with their development. So this is one of our children, earliest children picked up at JKM hospital when Professor Adupati was there. So that is a full-blown congenital hypothyroidism at 3 months of age with all the clinical features you would read in a book. Of tongue, no activity, both the fontanelles are open, And the same child, after the treatment has been initiated and improvement in milestones. He just came recently, he's about 20 years of age now. Because of the delay in diagnosis in this boy with athyrosis, he has not done very well academically, but he's a very useful citizen, and academics is not the only way to succeed in life. So he's gone ahead with physical labor associated profession to improve his life. We'll go on to the next case. This is a full-term normal delivery child with a cord blood TSH of 34. And what should we do? I would actually like to take all of you through this chart, which is very, very important and very useful in your clinical practice. Look at the first box. First, send a confirmatory venous sample for TSH and T4 or free T4 after 72 hours. The first box, you have a normal T4 and free T4 and TSH, so everything is fine. The TSH is less than 20 in the first 2 weeks and less than 10 beyond 2 weeks. With the T4 and free T4 in the upper half of the normal range, then this child is absolutely normal. Next box. You have a low T4 or a free T4, but the TSH is high. This is a problem in the thyroid gland. This is primary hypothyroidism. You will start thyroxine. If you don't have facility, start thyroxine straight away. You can image later. If you have to the third box, that low T4 or free T4 and a normal TSH, this is central hypothyroidism. And the T4 and free T4 should be in the lower half of the reference range or very low. Start thyroxine. You should check for other pituitary hormones for sure. Usually they come together. Very rarely you will have isolated growth thyroxine deficiency in central hypothyroidism. The last box, the T4 and free T4 are normal. The TSH is high. This could be transient or slowly evolving hypothyroidism. When you have a normal T4 and free T4, the CNS is developing well. This child will not have neurological disability. So it is up to you on how you want to proceed based on how you think the child will be compliant and the family will be compliant. Repeat TSH after 2 weeks. If the TSH is less than 10, this child is normal, leave them alone. This was a transient congenital hypothyroidism. There might have been antibodies or other reasons which were blocking, but the child has resolved. Repeat TSH after 2 weeks if it is more than 10. Because the TSH is persistently more than 10 after 3 weeks with normal T4 and free T4, you would not want to take a risk. You can start thyroxine. You can reevaluate later once the CNS development is normal. So I think I've given enough time. So you have one box or everything is normal, T4 and TSH. This child is normal. If the T4 is low but the TSH is high, then it is primary start thyroxine. The T4 is low, the TSH is normal, then it is central hypothyroidism. You will again start thyroxine. There is normal T4 and free T4, high TSH. This can be transient or slowly evolving hypothyroidism. So this is a Synthi scan in a child where there is a marker at the chin and the suprascapular notch. So you have a double ectopic thyroid gland in this child. This child had 2 ectopics, one at the base of the tongue and one at the root of the neck. This is a perchlorate discharge test which is done in patients with dysharmonogenesis. I've slowly weaned myself away from this. If you have a thyroid gland in the normal position with significant hypothyroid, both biochemically and clinically, this is definitely a dysharmonogenesis. So I have not pursued perchlorate discharge in the recent past. Duration of therapy, how long will you give? In structural abnormalities, which include athyrosis, which you have no doubt, ectopic thyroid gland, hemiagenesis, it is lifelong thyroxine replacement. I would like to remind you of the Tirukural, which talks about the strength of the crocodile being in the water and the strength of the elephant when it is in land. So where you should be originally will determine how strong you are. So when you are out of your normal position, you cannot function normally at all points in your life. So you need lifelong thyroxine replacement. This hormonogenetic congenital hypothyroidism. The thyroid gland is in a normal position, but it is not functioning well. Treatment can be stopped for 4 weeks if you take a much more, what would you say, a conservative approach. Treatment is stopped for 4 weeks at 3 years of age to reassess whether this is transient or permanent. The thyroid functions are normalized. I will still keep a watch for about a year and again at puberty because some of my thyroid transient hypothyroidism have later evolved into a mild congenital hypothyroidism needing thyroxine replacement. Permanent congenital hypothyroidism with the TFT is again out of range with the T4 and free T4 being low and the TSH being high, then you will restart thyroxine and that is for life. You have confirmed the diagnosis that it is a permanent congenital hypothyroidism. We'll go on to the next case scenario. You have a cord blood TSH of 10.2. And what I said earlier, when you have less than 20, it is normal. The child is clinically well. There is no thyroid swelling. This child is discharged. During the first immunization, the child presented with slightly dry skin, passage of stools which were hard on alternate days, and during subsequent immunizations, there was a slight delay in milestones. So the initial thyroid screening was normal. The child was otherwise well, but later had some clinical features of hypothyroidism, but the pediatrician thought since the initial screen was negative, they did not pursue this. Remember, whatever said and done, you can still have congenital hypothyroidism because initial screening may miss 2% of congenital hypothyroidism, which is 1 in a million population. So if you suspect clinically, repeat full spectrum thyroid function test. The reasons may be it is a secondary or a tertiary hypothyroidism or a slowly evolving hypothyroidism. What did we talk about? It is newborn thyroid screening. It is only a screening test. It is not a confirmatory test. So if you have doubt about screening, please go ahead and repeat a full-blown thyroid function test. So this is the child who had full-blown hypothyroid features at 6 months of age. The head control had not been achieved yet. Anterior fontanelle was wide open. The posterior fontanelle was open. You can see the bubble loops, the slightly protuberant umbilicus, and this child had a full-blown congenital hypothyroidism picture. When the hypothyroids are diagnosed late, particularly in full-blown hypothyroidism, I also see a bit of squint in them, which I haven't seen being mentioned in any of the books so far. So this is the same child after appropriate thyroxine replacement, and she's currently doing well. She's about 14 years of age. So this is a teenager who had been branded as a psychotic because she was talking to herself. They thought the devil had gotten into her. She was isolated in a separate house. They had taken her to a nearby hospital, but nobody gave importance to this protuberant abdomen, which was shiny with fluid retention. There was no obvious thyroid swelling because it was not very obvious in this girl, but you can see the dry scaly skin and the non-pitting pedal edema. So that was an acquired hypothyroidism or autoimmune hypothyroidism that can present with goiter or not, because sometimes it's just soft and uniform. So it may not have the structure of the thyroid gland, particularly if it's a bit large. Delayed growth, mild weight gain. Please remember, not everybody who is obese can only have thyroidism. It can be, amount of obesity is usually not proportional to the hypothyroidism. Lethargic skin, constipation, puberty can be early, delayed, or associated with menstrual irregularities and psychological issues. If you look at the prescription of any psychiatrist, the first test they will do is check for thyroid functions. Because it's a very important, not all thyroid patients have psychotic issues, but all psychiatric patients are evaluated for thyroid because that is something which they can treat and make them better. What is the dose of thyroxine and acquired hypothyroidism? It is started based on weight or body surface area. It is continued lifelong. If somebody says, I have stopped thyroxine after the initial few months or years, that means the initial diagnosis is suspect. It is continued lifelong. You start at a lower dose and step up gradually, particularly in full-blown hypothyroidism. Dose, the secretory rate of thyroxine or requirement of thyroxine for our body is 80 to 120 micrograms per meter square body surface area, roughly around 100 mics per meter square body surface area. Or if you use it per kg body weight, age 1 to 3 years, 4 to 6 microgram per kg body weight, 3 to 10 years, 3 to 5, 10 to 16, 2 to 4, and in young adults, it's 1.6 to 1.8 mics per kg of ideal body weight. Further dose adjustments is adjusted to maintain TSH and T4 or free T4 in range. Please remember, in congenital hypothyroidism, we will start at a higher dose and climb down because the faster you normalize your TSH, the better the long-term outcomes are. In acquired hypothyroidism, you will start slow and climb up because you need to give time for the body to adjust and adapt to this dosage. In severe, prolonged acquired hypothyroidism, when a full dose is started, I have seen children go into convulsions. You might also precipitate cardiac failure because you're beating up a dead horse which hasn't had time to wake up. So in acquired hypothyroidism, please follow this table. You have an abnormal TFT, where the TSH is normal, but the T4 is low. If the T4 is low, but the TSH is normal, please check the free T4 in these patients. It's extremely important in them. It may be just a plain thyroxine binding globulin deficiency or a hypoproteinemia, which does not need thyroxine replacement. If you have a normal TSH and a low T4, you will do a FT4. And if it is low, it is central hypothyroidism. You have to start thyroxine replacement. TSH is 5 to 10, which is actually in children, abnormal TFT is the TSH of more than 10. When it is 5 to 10 and the T4 is normal and the antibodies are negative, it could be due to obesity, which is actually because of leptin-like effect. It can have a transient or a increase in TSH, which is not actually pathological. It does not need thyroxine replacement. It could be due to drugs. You can repeat the thyroid function test after 3 months and review what you want to do. If the T4 is normal, but the TPO is positive, that means they have autoimmune thyroiditis. It may be an evolving acquired hypothyroidism. Please repeat the thyroid function test every 3 to 6 months. I have children who have positive antibodies with a normal T4 and have been in autoimmune thyroiditis states in the youth thyroid states even for several years. But some may evolve in a few months. Trying to find the etiology for this. You have an 8-year-old girl whose BMI is more than 95% for age. Her T4 is 7.5, which is within the range. Her free T4 is normal within the range, 1.4. Her TSH is mildly high, which is 5.96, which is just beyond the cutoff of that lab at 5. The antibodies are negative, and this child was started on 12.5 micrograms of thyroxine. And this was the case I was talking about. This is obesity-induced TSH elevation. Stop thyroxine and re-evaluate. We have another girl who's 13 years of age, constipated, tired, sleepy, has a menstrual cycle which happens once in 40 days. She gained 6 kgs in 6 months. Her T4 is 3.6, which is lower than the cutoff. Her TSH is 2.2, and the other systems are normal. Again, she's constipated, tired, sleepy, with irregular menstrual cycle, and she has actually attained menarche only recently. In the sense, she had attained her menarche about 9 months ago, and she had a T4 which was low and TSH which was normal. So they thought she was hypothyroid and started her on thyroxine. But when they did a free T4, you have to do a free T4, it is normal. Just because in the first year of attaining menarche, the periods can happen at its own whims and fancies. It is not irregular cycles. It is not significant. Gaining weight is because she's not been exercising enough and playing enough. So this was a thyroid hormone binding protein abnormality. It could be TBG or a hypoprotein. So it happens 1 in 4,315 infants. It is more common in boys. Boys is to girls is 9:1. The T4 is low. Free T4 is normal. TSH is normal. If unaware, unwanted investigation and treatment with thyroxine for central hypothyroidism would have been done. I think this would be my last case scenario. 15-year-old girl, normal height, weight, and intellect. Attained menarche in September 2015. She had 7 days flow. No other period since then for 4 months. Remember, I said for the first year of it is actually irregular periods is defined from the post-menarcheal age. You are not looking at the age of the children now. The first year of after attaining periods is called first post-menarcheal age. So this is the first post-menarcheal age. She had no other period since then for 4 months. The family was worried. They consulted an obstetrician. They checked the thyroid functions. TSH was 1.3, which is normal. The free T4 was low, which is less than the cutoff in that lab. She was started on thyroxine. She developed headache within a week. So the family blamed the thyroxine and stopped thyroxine. She had vomiting and she developed dehydration and tiredness and was treated with IV fluids and was referred for treating thyroid dysfunction. Please remember, in a child who has attained normal height and weight and intellect means her thyroid functions have been normal since recently. She attained menarche means her sex steroids are fine and probably the hypothalamo-pituitary gonadal axis is working probably well. But she had a good 7 days flow. She had no other issues, but she has suddenly developed central hypothyroidism. So in a previously well-functioning pituitary, if you suddenly develop central hypothyroidism, it is an ominous sign. So she has had normal height, which is growth hormone is normal. She had a period, her FSH and LH are normal. She had her intellect is fine. Her height is normal. So all the pituitary hormones have been normal. But suddenly she develops hypothyroidism. This is a report of the child. This is an ominous sign. There is a space occupying lesion in the central region surrounding or near the pituitary, which has caused a central hypothyroidism, unless proven otherwise. Because in a previously well-functioning pituitary, you cannot develop a sudden onset of central hypothyroidism without any triggering factor. So she had a malignant glioma, and she actually was referred to the neurosurgeon. And before they reached the hospital, she had already lost her vision. Thank you so much.
Thank you, Dr. Akila, for that very exhaustive discussion. One point on the last case which was not clear was the TSH was in the normal range, the last case scenario of the child with ICSOL. So I was all along under the impression that if it is central hypothyroidism, TSH and T4 and free T4 all will be pointing downwards. But here in the last case scenario, you put TSH was normal. So what made you suspect central hypothyroidism? You're muted. Can you unmute, please?
So her TSH was inappropriately low for the free T4. So when her T4 would have climbed down, her TSH should start climbing. It has not climbed. So it is the maximum amount that the pituitary can produce even in the presence of severe hypothyroidism. And she was a previously well child. In a previously well child, you cannot develop central hypothyroidism suddenly, and that too within a short duration. It is usually a space-occupying lesion, unless proven otherwise, and usually malignant, because it's a very fast evolving issue, because it's just started recently within the past months.
Okay, that makes sense.
Only
We will
only
probably
clinical
give you a couple of minutes for rest.
yeah, only clinical feature I would examine, I checked for, was confrontation test for the field of vision.
Probably papilledema, something like that. Dr. Akanshka, are you ready to take a couple of questions? We'll probably give Dr. Akhila a bit of rest before we bombard her with more questions.
Sure, sir.
Okay. We've always been told that if you have an autoimmune process, there will be some immune mechanism which is gone awry, and then we almost always give some sort of immunomodulation. But when we are talking about two pediatric endocrine disorders, which we all manage, we are quite happy to only treat the end organ deficiency instead of addressing the primary pathology. And very specifically, we have an autoimmune thyroid destruction, Hashimoto's manifesting as hypothyroidism, and we have type 1 diabetes where we know reasonably well that the pathophysiology involves autoimmune destruction of pancreas. So why is it in both the places that we are happy to give insulin or thyroxine rather than treat the underlying disease with some sort of immunomodulation?
Yes, so before I answer this question, I would just like to say thank you and express my gratitude to IIP Tamil Nadu as well as Dr. Ahila ma'am for giving me the opportunity to be here. I think this is it's a wonderful question, sir. And in these two particular cases, I believe especially in type 1 diabetes, the research on immunomodulation is going on. We have achieved at a medicine where we may be able to prevent the progress of type 1 diabetes to a certain extent. Yet, till date, at present, immunomodulatory therapy in these two conditions is not seen to be effective in stopping the primary disease process. And in both these cases, we do have simple treatments available in the sense of in an autoimmune thyroid condition, we do have the end product, which is levothyroxine, which can be easily administered. It's easily available, easy to take. In the same way, we do have insulin therapy, which we can give. And since at present, we haven't seen that immunomodulatory therapy can prevent the progress of the disease, we don't really have a choice as of now. Tomorrow, maybe we may encounter medicines which can prevent the disease progression. But as of now, we don't. Maybe Dr. Ahila can add to that as well.
So actually, if you think of steroids, the effect of steroids are worse than the disease. It does not reverse autoimmune hypothyroidism. So there's no point in trying it. And when you use steroids in type 1 diabetes, you're going to make the sugars go out of range and very difficult to control. It is not going to reverse the type 1 diabetes either. You use immunomodulatory therapy and steroids in SLE and other connective tissue disorders because it can reverse or save the children from the effects of the disease. But here, they don't have any role. But as Akanksha mentioned, there is a drug called teplizumab, which is being used in patients with positive antibodies. They have various stages of the autoimmune process in type 1 diabetes, but before the onset of disease. And again, it can only postpone the disease. It cannot stop it so far. So we'll have to wait for better agents.
Perfect. Thanks for the answers. Dr. Akanshka, Dr. Akhila had very clearly made up a very nice algorithm that we can all use. But unfortunately, as we understand, most congenital hypothyroidism are either disorders of thyroid dysgenesis, migration, or their dysharmonogenesis. To prove the first one, we would need a technetium 99M scan, and to confirm the presence of dysharmonogenesis, we will need a scan showing an intact thyroid gland, and we'll probably need a genetic study to find out which particular step in the thyroxine synthesis has been blocked. Now, as we practice in very varied setups, it's very difficult for a practicing pediatrician to have access to both these tests. So my question to is, can we bypass this algorithm? Sticking to the biochemistry, fine, but can an ultrasound of a thyroid in its normal location be taken as sufficient proof of a dishormonogenesis or a transient receptor antibody blocking? Is that an accepted algorithm, or would you insist on the technetium scan being done?
So, sir, I wouldn't insist on it being done because, as you said, it may not be readily available for all practicing pediatricians. And to be very honest and to be very fair, it really doesn't matter in terms of treatment whether you reach the etiological diagnosis or not. Now, having said that, although as pediatric endocrinologists, we do say that if available, then it would be a good idea to get the technetium scan or a nuclear scan done. And in practice, we know it helps us because one, we can provide to the parents a definitive diagnosis telling them that, look, the thyroid gland has not been formed and the baby is going to need treatment lifelong. Secondly, somewhere it also helps us in determining the dose. So if you have a dose range that we can start, and if we know that the baby has a thyroid agenesis where no thyroid hormone is being produced at all, it helps us to choose the higher dose over the lower one if both are present in the possible treatment range. Having said that, again, I would like to reiterate, that if the initiation of treatment is not going to get delayed, then we can go ahead and do the scan. However, if it's not possible for whatever reason, then we can suffice with the USG thyroid. One last point that I would like to make is sometimes it is very difficult to pick up a thyroid gland in a newborn. And very often, a pad of fat or a lymph node may be misdiagnosed as a thyroid gland on a USG. So recently, we had seen a child who was diagnosed as a hypoplastic thyroid gland on the USG. And when we did a nuclear scan, turned out to be an ectopic thyroid. So this may be, I guess, a viewpoint. Maybe this is just academic. However, for a practicing pediatrician with limited access to these scans, we can definitely go ahead with just a simple USG.
Perfect. Before we leave thyroid and go on to other endocrine issues, there's one practical problem that we are increasingly facing, and we would like both of your opinions on that. It is basically the awareness that all autoimmune and immune disorders seem to be rising pretty fast. I'm not sure whether it is a bias which is sitting in a corporate hospital or whether it's happening in the community at large. You would be able to say better. But we are seeing more and more women with anti-TPO antibodies getting pregnant and delivering babies. I want to know from both of you, what will be the effect of the anti-TPO antibodies? Since they are IgG and they can cross the placenta, is there a chance that these babies will have a transient TRABS, which will be mislabeled as congenital hypothyroidism on the screening? What would you suggest we do for such babies?
Ma'am, should I go ahead? Okay, so yes, you're absolutely right. Mothers who have antibodies positive, the antibodies can pass across through the placenta and can sometimes cause a transient neonatal hypothyroidism. This would be picked up on the newborn thyroid scan. And in all such children, we do ask for history of autoimmune disease. For autoimmune disease in the mother. And
Dr. Devendra Sarin, ma'am, please. Dr. Devendra Sarin, can you please mute yourself? Thank you. Thank you, sir. Ma'am, please continue.
And if we do have this history of anti-TPO, anti-TG antibodies positive, we can test the newborn as well to see whether the newborn has those antibodies as well. If we do find them positive, then we do follow up these newborns to make sure. And if the TSH level is high, some of these newborns may even need treatment for a while.
Perfect.
Antibodies can last for about 3 months at a maximum. And so these newborns will have to be followed up closely to see whether they need treatment after that as well or not.
So the last case scenario that you're saying is a genuine transient, but nevertheless probably clinically relevant congenital
Yes.
hypothyroidism that can be picked up on the newborn screening. Perfect.
Yes.
Thank you, ma'am. We have a couple of questions relating to thyroids in the chat box. If time permits, we will come back. But because pediatric endocrinology is such a vast ocean and we are still stuck at the thyroids, we thought we will discuss a couple of more vexing practical pediatric issues related to endocrinology before we probably take on more questions on thyroids. Ma'am, one of the common presentations that a general pediatrician faces is the children between the age group of 1.5 to 3.5 or 4 who are brought with history of early morning unarousability in the bed, not feeling well in the mornings. They have probably even convulsed. Sometimes they come with a history of vomiting followed by lethargy, loss of consciousness, or disturbed arousability. And when they come to the hospital setup in the ER, we do a glucose sticks and we find values typically between 60 and 70. Sometimes the parents recall that the babies were discovered lying in a pool of saliva, and the parents believe that the child might have thrown a seizure. So we, in the setting, make a diagnosis of substrate limited hypoglycemia. Are there well-defined criteria to substantiate this diagnosis? Can we give them better advice other than telling them to avoid prolonged nocturnal fasting? Do other conditions like glycogen storage disorders or fatty acid oxidation disorders also present like this? How do you go about this particular case presentation? Hypoglycemic toddler or a young or a slightly older infant who is found unresponsive in the bed, and the only clue we get is a low glucose.
Akshay, go ahead.
Okay. So, when we say substrate limited hypoglycemia, or what we call as ketotic hypoglycemia, it's actually a diagnosis of exclusion. And, very importantly in such children, going back to the basics is a good history and examination. What we really want to look for are some red flags. Red flags in the sense of consanguinity in the parents, previous siblings having a similar history, neonatal hypoglycemia in this child, or previous episodes of hypoglycemia in the present child, developmental milestones, whether they're delayed or not, and also examination findings in the sense of growth. A short child may indicate hypopituitarism as a cause. Midline defects, presence of midline defects such as cleft palate, a microphallus, again indicating hypopituitarism. Dysmorphisms, some syndromes can be associated with hypoglycemia, and a hepatomegaly that would also favor, say, an inborn error of metabolism like an FAOD or GSD that we're talking about. So, and of course, in all of this, one must also, it's very, very important to take a critical sample whenever possible. So if you have a baby or a child who's coming with a hypoglycemia to you, very often we're in a rush to treat it. And it's always better to, take a moment and prepare oneself and get that critical sample, because that is the most helpful when it comes to evaluating the cause of hypoglycemia. I think Ahila ma'am wants to show the same, I think.
Thank
Dr.
you,
Akila,
Akansha,
that looks like a very busy slide. Can you please walk us through this? Yeah.
So this is an article which I wrote on a short approach to low sugar. So we'll take out the diabetic child, which is on the right. We're looking at non-diabetic child. As Akanksha mentioned, the critical sample is absolutely essential. And if you cannot do anything, please do a ketones in that. That will help us narrow down the diagnosis so beautifully and also help us in the outcome and treatment of these children. A glucometer to measure ketones is easily available. The ketone strips cost roughly around 100 rupees or so. Any hospital can always have a ketone meter or a glucometer which can also measure ketones. In a non-diabetic child who has a low blood sugar, and remember, this has clinical symptoms of hypoglycemia. You draw a critical sample for glucose, ketones, insulin, cortisol, growth hormone, and store some sample for other tests. If the blood ketones or more than 2 millimoles per liter. Less than 0.6 is normal. More than 3 is high. Anything more than 2 millimoles is a ketotic hypoglycemia. If you have ketones which are negative, then you will check the urine for reducing substance with a Benedict's reagent. Don't use a glucose strip. It measures only glucose oxidase. It cannot measure the other reducing substances. The reducing substances are positive. It is hereditary fructose intolerance or galactosemia. If it is negative, you measure the insulin. If the insulin in the presence of low blood sugar should be low. Once the blood sugar goes less than 85, the second point of low blood sugar, if the plasma insulin is more than 2 milliunits per ml, it is hyperinsulinism. If the plasma insulin is less, then it is probably a fatty acid oxidation defect. If the child has ketotic hypoglycemia, measure growth hormone and cortisol. If the growth hormone is more than 6 and the cortisol is more than 20, that means the endocrine axis is normal. Examine for hepatomegaly. If it is present, you will think of glycogen storage disorder. If there is no hepatomegaly, think of ketotic hypoglycemia. If the growth hormone is low or the cortisol is low, you will work up and evaluate for hypopituitarism. I would say that is a simple algorithm for hypoglycemia.
Thanks for walking us through that. Can we have that algorithm again, please?
Oh, just.
So my doubt was whether hereditary fructose intolerance, why would it interfere with ketogenesis? That would come under ketotic hypoglycemia, no? Hereditary fructose intolerance.
This is the one part of the slide. It took me so many days. I looked at several articles and finally some said it is positive, some said it is negative. So I actually put it down as non-ketotic because some of the articles were specific that it is non-ketotic.
My understanding was that aldolase should not interfere with ketogenesis. Anyway, thanks for walking us through that slide, Dr. Akila. Dr. Akanshka, question back to you.
Yes.
Ma'am, are you with us? Yep. Ma'am, with improving neonatal care, we are seeing more and more of micropremies being brought out to the world and very doting parents who want to give their children the best start. So can you please tell us, because after a particular point of time, they are happy to follow with the gender pediatricians, and we are quite clueless to understand how long it will take for these preterms, micropreterms, extremely small for gestational babies to catch up. Unfortunately, in India, as we understand, we don't have preterms, SGAs who are term and SGA as a clear cut. Most of our babies that we see even in the corporate setup have varying combinations of prematurity and SGA. So how long can we wait for catch-up growth to occur in head circumference, in linear growth, and in weight? When do we start worrying about a lack of catch-up?
Yes, so we do, short stature in children where children are born preterm, SGAs, and even IUGRs do form a considerable proportion of patients that often get missed, I would say. And these children, right from the time of birth, need to be monitored for catch-up. Most of the catch-up growth does happen in the first 6 months, if not at least in the first 2 years. In Indian children, it may take up to 4 years for catch-up to occur, and that's what's been seen. So practically, I would say, when should we intervene in terms of, say, growth hormone therapy in such children? Because we do know that SGA children, with short stature is an FDA-approved indication for growth hormone therapy. So practically, if you see a child who is 2 years old, who is far below the third centile, this may be a child who may benefit with growth hormone therapy. Whereas if you have a child who is just below the third centile, you may choose to wait till the child touches about 4 before you start or consider growth hormone therapy. So, to put it sort of simply, the head circumference should catch up by 6 months. And it's the height that we would follow up long term, maybe till about 2 years or maybe 4 years before one can start or can consider growth hormone therapy?
Dr. Akhila, considering growth hormone therapy, we see also there's an ever-expanding spectrum for offering growth hormone therapy. As a general pediatrician, we are quite confused because initially we were giving it subcutaneously in the night. Now suddenly we are told it needs to be given only once a week. And then we have had papers from Dr. Vaman Kadilkar saying that biosimilars from India may be as good as the brands from abroad, which are very erratic in their supply and beyond the reach of many parents, at least for sustained administration. Can you please tell us the practical applications of growth hormone therapy, whether the biosimilars are acceptable, and what is this thing about weekly growth hormone therapy? Are they pegylated forms or are they just long-acting forms? Can you please illustrate?
So as mentioned by Akanksha, all of us know once you have established growth hormone deficiency, there's no doubt about starting growth hormone therapy. But the doses required for severe growth hormone deficiency is actually a bit small. It's quite small. They have excellent growth even on very small doses because they're deficient and they're need for growth hormone. When you give growth hormone for other indications, the doses are different. So it's actually the dose is dependent on the diagnosis. In small for gestational age infants, as already mentioned by Akanksha, if they don't catch up by 2 years, it's actually an indication for growth hormone. But in India,
Sorry
we
to
still
interrupt. When
continue
you
to
say, sorry to interrupt. When you say when they don't catch up, are we talking about the height for age, weight for age, or head circumference? Which aspect of growth are we talking about?
only height. It's only
Height.
height.
Okay, right. Please proceed.
It's only the length. Yeah, so it's only the length, but it also has it has a lot of beneficial metabolic effects also in SGA. So the indication is not only for height, it's for metabolic benefits, not for the weight or for the head circumference. It's more to do with length and metabolic effects. So doses are different. Definitely they are higher than that used in the growth hormone deficiency. And in India, we usually wait till 3 to 4 years, but they have significant growth failure beyond 2 years. We do start. You don't have to do a growth hormone stimulation test to start growth hormone therapy in SGA babies. The other indications, I think almost everybody would know. Renal failure, and then all other indications, including idiopathic short stature. There are several syndromes, including Turner's, Noonan's. Even there's a recent paper, a meta-analysis on use of growth hormone in Down syndrome. So it's ever expanding, but the definitive indications are growth hormone deficiency, SGA, Turner syndrome, and then when you have significant growth failure based on anthropometry. Anthropometry always takes precedence over all blood tests and any other evaluation. Next, you will also, we're talking about different kinds of growth hormone. Yes, it's daily growth hormone. We were trying to mimic the nocturnal secretion of growth hormone by giving the doses in the night. But the weekly growth hormone in practice seems to be working as well as the nocturnal daily growth hormone. It is not a pegylated form. Pegylated form is available in China. The one which is available in India is Pfizer, which actually uses a truncated form of the GnRH. A part of that molecule is attached to just prolong the life of the growth hormone. It is not equivalent milligram or microgram per microgram. It's actually a totally entirely different product. So the dose is dependent on the evaluation and the tests that they have done so far. It is indicated only for growth hormone deficiency in India so far, because the Turner syndrome and idiopathic short stature for the Pfizer one is yet to complete. It's already on the way abroad. We are starting the studies in India in the recent future. But long-acting growth hormone from Novo Nordisk, somapacitan, has actually been approved for Turner syndrome also. And the biosimilars are definitely good. They are not bad at all. I find them as effective, or probably just 95% of efficacy of the original products are seen with the biosimilars. I have no hesitation in giving them. But you have to look at the shelf life of these growth hormone products that are available. Like if you have the Sun Pharma one, you're not supposed to keep it beyond 1 day. You have to use as much as possible and discard. But we don't such an expensive medicine, we actually just split it and still continue to use it. There is one from the Reliance, which they say is potent for about 14 days. So each of these growth hormones have a different shelf life. The only thing is they are using syringes to draw and give. Whereas it's coming by a pen when you have the international ones. And the long-acting ones are, yeah, the expense actually, if you look at the daily growth hormone from Pfizer and the weekly one, the difference in cost is not too much. But between the biosimilars and the imported ones, it's almost half the price of the international ones, the biosimilars. And they're very effective also.
Thanks for those delightful pediatric, those tidbits which are so relevant to the practicing physician. Well, we have briefly glimpsed into growth hormone and its intricacies. Can we probably take a peep into type 1 diabetes, G? Dr. Akanshka, what are the recent advances in insulin formulations or administrations that you would like the general pediatrician to be aware of? Is there some path-breaking stuff that's happening there?
So, insulin has been around since the last 100 years. We don't have another medicine, but with time, the insulin preparations have also been changing, and they're continuously changing. What we are trying to do is to try and mimic physiological insulin as well as possible, and to try and achieve the best control for every child without complications such as hypoglycemia or a variability in their sugars. Now, for that, today, the most recent insulins that are available are what we call as ultra rapid acting insulins, which are bolus insulins given before meals. These insulins are very quick insulins, such as Fiast, Lumjev, what their trade names are. And these are insulins which are given, and then one would eat a meal within 5 to 10 minutes of giving this insulin. So previously, where regular insulin, we would have to wait for 20 minutes to 30 minutes before eating. Here, we can give it and we can quickly eat a meal within 5 to 10 minutes. And they're, of course, preferred by children who need to take doses in school, etc. For the basal kind of insulin, which are long-acting insulins, today the newer insulins available are what we call as Digludec and U300 glargine. These are called as ultra long-acting insulins, which tend to stay in the body for 48 to 72 hours. And where these help is the chance of hypoglycemia when one uses this is reduced, and the variability of sugars also reduces. Now, not just the insulin, but the way in which insulin is given is also changing. Initially, it was syringes. Now we give through pens. And of course, what has been available recently are insulin pumps. Just to finish off with the insulin today, though it's not approved in children at all, in especially type 2 diabetes in adults, what is also available today is Icodec, which is once a week insulin. Which is again an ultra long acting insulin, but this has been approved for type 2 diabetes in adults and not in children.
Okay. Well, we probably will take one more question on diabetes before we move on to other aspects. Now, when we are doing so much of immunology is changed, so much of immunomodulations, immunosuppressions have been available. We are transplanting livers with impunity. We are doing stem cell transplant. Now, why would type 1 diabetes be looked at differently? Is it that the transplanted pancreas will also succumb to the same disease? Why would pancreas transplant not be an important therapeutic option in type 1 diabetes?
So today, pancreatic transplant is actually approved in type 1 diabetes only if there is a associated kidney transplant being performed. And one of the deterrents of doing pancreatic transplant is the need for lifelong immunosuppression post the transplant. So these children may become insulin free for a few years. However, the benefits are outweighed by the risk of lifelong immunosuppression in these children. And therefore, today, pancreatic transplants in type 1 diabetes is not approved. And people are looking at other forms of, other ways in which it can be cured, like stem cell therapy. And that too, the problem with stem cell therapy again was the need for lifelong immunosuppression. And so there was a research going on about encapsulated stem cell therapy where we wouldn't need immunosuppression. However, unfortunately, the trial was stopped because it failed, and they couldn't prove success in such a case. So the major deterrent today is the availability of a donor and lifelong immunosuppression in such cases. Ma'am, would you like to add something to it?
Yeah. There's a recent presentation at the American Diabetes Association this year, which talked about genetically engineered stem cells, which can evade immunosuppression and can be implanted easily, but it's in a very, very early stages of trial. Any drug which comes into use has to be used for at least several years in the adults before they can come to children. All transplants so far have not proven successful. If you look at authentic, good data, the only data which has actually been very good with their presentation was from the UK. They only showed that it reduced incidence of hypoglycemia, and even that it was in very old people with type 1 diabetes for a long time, and they went back to full requirement soon. So we're looking at and waiting for these trials to happen to see whether you can modulate these cells to, which may not need immunosuppression, but that would be in future, we'll have to wait.
Okay. So question to you, Dr. Akhila. This is because of the global epidemic of obesity. We are all very happy to keep giving dietary advice till kingdom comes. We know, and the patient also knows that they are not taken seriously, or at least probably 10% to 15% stay motivated to lose weight by following diet and exercise. And we have on the other side the availability of glucagon like peptide agonists and SGLT inhibitors. Are they approved for weight loss? Are they approved in the management of type 2 diabetes? What is your experience with type 2 diabetes in obese children?
The only drug that actually works, if you have a HbA1c of more than 9, internationally it's recommended you start with insulin and then add oral drugs and gradually wean off insulin once they are into control. But it's a terrible agony for the family. They would not accept. So quite frequently I've tried only with the metformin. But you have to be very, very careful, remembering even obese children could still have type 1 diabetes rather than type 2. So the rider has to be that you keep a very, very careful watch on them. It may be an obese child who has developed type 1 diabetes, because type 2 diabetes is very rare. It can happen. When it happens, you can use metformin, which is approved for use in children too. SGLT2 inhibitors, I have never used in children. Even in adults, I'm a bit worried about it. They feel depleted of all strength, feel so tired. You have to go to the loo all the time. It's really a difficult drug to use. And the next one is GLP-1 analog. It's approved for use in obese children with type 2 diabetes beyond the age of 12 in the US. In India, it is still not approved for children under the age of 18. The tirzepatide, which is a GLP-1 GIP combination, is again not approved for anybody under the age of 18. But they will be useful drugs. Please remember, whatever drug you use, you still have to follow lifestyle modification. Without diet and exercise, even GLP-1 analog cannot produce meaningful results.
Okay. What about appetite suppressants for children who are making a genuine effort to lose weight, but they are not able to? We are still on the subject of obesity, leave out diabetes, as pharmaceutical measures to reduce weight. Where are we? How many drugs are approved?
Phentermine, topiramate combinations and buprenorphine, nothing has worked actually. They are all approved for use, but I have never seen them work.
Okay. Dr. Akansha, touching on another very important topic that all the pediatricians should be well aware of. How do we pick up the non-classic presentations of congenital adrenal hyperplasia? How does it present? How do we keep our antennae out to pick up the simple virilizing or the non-salt losing types? What do we keep our antennae out for? How do they present? How do we pick up the diagnosis? With 17-hydroxyprogesterone still be the go-to test in a child who presents, say, at 6 months with a hypotensive shock, hypoglycemia following a trivial attack of acute gastroenteritis?
So, simple virilizing CAH is a classic form of CAH in which there is some amount of enzyme activity present so that these children usually don't go into a salt wasting crisis. However, girls with simple virilizing CAH do have genital ambiguity, and they present right at the time of birth with genital ambiguity. In boys with simple virilizing CH, they may be actually missed, and they often present during childhood with isosexual precocious puberty, which means they can come with tall stature, with increase in penile size, underarm hair, pubic hair, and a muscular build. And this is what makes them present to us. Um, Most girls with, if you have a girl with a mild form of simple virilizing CH, she may be missed during newborn period or maybe infancy. And these girls can also come during childhood with increasing virilization, typically increase in clitoral length. And that's how they would be picked up. For children with the non-classic CH, they would come, they have enough enzyme activity, and therefore they would come at an older age, say at about after 7 odd years of age, or after 6 odd years of age, with what we would call as premature puberty, which means an early onset of axillary and pubic hair. They can come later with menstrual irregularities and with hyperandrogenism in the form of acne, and yeah, right. So acne. And for these children also, the initial test would be a 17 OHP level and a cortisol level. The gold standard, as is considered today, is what we call as an ACTH stimulation test, where we stimulate the adrenal glands to see what is the maximum production of cortisol and 17 OHP, and we look at their cutoffs.
Perfect, ma'am. When it comes to the newborn with atypical genitalia, we often say the phallus appears small, the phallus looks small. Is there an objective measurement? Do we have established measurements for penile lengths in babies to say this is -2 SD, less than -2 SD, or is that one value below which everything is considered microphallus?
So, I mean, normally, if you see Nelson, they would say that for a term newborn, a phallic length less than 1.9 centimeters would be considered as microphallus. We do have Indian cutoffs today for Indian children for the -2 SD deviation. However, I would like to say that you know, it's not just the measurement of the stretch penile length, but in toto the clinical picture. So if you have a baby with say genital ambiguity or microphallus, along with say hypoglycemia, which could be an indicator of adrenal insufficiency, along with failure to thrive, or you know, hypotension, dyselectrolemia, all of these do point towards a possible underlying you know, possible adrenal insufficiency or maybe a DSD.
So what is the absolute minimum investigation that you'd like a general pediatrician to do when he is confronted with a baby with atypical genitalia? We are now, the obstetrician transmits all the pressure onto us. So the parents and the families, the first thing they ask whenever a baby has been born is whether it's a boy or a girl. And it's quite devastating to tell them we are not sure, because the management also says assign a sex of rearing to this baby. We cannot have an indeterminate sex in the medical records. So to document the presence of Y chromosome, would you care to comment about the utility of fish analysis and its turnaround time? Or does it miss genuine cases where you may have true chimerism, 46XX and 46XY? Even the presence of Y chromosome does not confer masculinity. Where does the law stand on this?
I think it's a difficult question, and it probably has a difficult answer because there's really no one t-shirt that fits all. But yes, if the approach to a newborn, particularly with genital ambiguity, I think would be to say whether you can palpate gonads or not. If you cannot palpate gonads, you're probably looking at a virilized female. And in such a case, one of the first things that we do is we ask for a USG of the pelvis to look for the presence of Mullerian structures like the uterus and the fallopian tubes. And if you can see a uterus present, then you're most likely dealing with a virilized female, of which the most common cause is CAH. On the other hand, if you cannot feel the gonads, then you're probably dealing with an under-virilized male. And in such a case, you would still ask for a USG to look for whether you can see Mullerian structures or not. But in such cases, when we talk about, establishing the sex, yes, a fish would help us because it has a shorter turnover time. It can give us the answer to the presence of a Y chromosome within 48 to 72 hours. As vis-a-vis a karyotype, which can take about 2 weeks for the result to come. However, the presence of Y necessarily may not always, favor raising the baby as a male. So there are two questions. What is the genetic sex of the baby? And what would it be best to rear a particular baby as? And both of these may have a different answer.
Absolutely.
The third point that I would like to make is that the evaluation of a DSD in most cases is never an emergency unless you're talking about CAH. So at a pediatrician level, if there would be a test that one would do, it would be to rule out a life-threatening condition like congenital adrenal hyperplasia, and a minimum of at least a cortisol and a 17 OHP would need to be done.
Dr. Ahila, knowing you to be a passionate advocate of children with DSDs, your final say before we take a couple of questions and wrap up today's session. Your final summarizing points.
For DSDs, as Akanksha said, I would only worry about CAH because it's life-threatening emergency. If your cortisol is high, it is useful. If it is normal or low, I would still look at a short-acting ACTH stimulation test. Because cortisol is the absolute imperative thing that I'm looking at, and for adrenal insufficiency, because the child can crash in time. Anything else, I would wait and watch. The next, as she mentioned, again, I would do an ultrasound to look for uterus. Again, I have simple, small clues which have helped me in the long run. Y chromosome, I have never tried fish for Y chromosome. Would have a mixed gonadal dysgenesis, could have a partial androgen insensitivity, any of that, but they're all not an emergency. The only thing I would request all pediatricians is, if you have mentioned the sex as indeterminate when the child was born because you could not make out what it is, when the child comes back a full-fledged diagnosis, please help them to get a certificate with what they are. They run from pillar to post, and I find it heartbreaking. Nobody wants to get into a problem, and nobody is willing to give in writing that this can be gotten. I feel very heartbroken at how much of trouble the family goes through. So I don't want to say what all kurkuvali I used to get the certificate from them. But I really find it's not the child's fault or the parents' fault that this happened. It just happened. We might have to help as much as possible. I think that is one responsibility and one request I would make to all pediatricians to help these families face this with equanimity. And all my children with DSTs are doing extremely well. Never take a stance saying you are 46 XY. It does not mean XY does not mean you are a man or a woman. It is how you feel. And we have to respect the decision of every individual. And I think we have to open up our minds and heart to understand these children with a little bit of empathy so that they go through life with a lot of, they already come with so much of difficulty
stress.
as a family, from the social circles. You won't believe they would not take off they don't even let the child live with anybody except the mother and the grandmother, because they don't want somebody to make a call on that. I've known families which have tried to commit suicide, the grandmother, mother, and the child. So all that I think is you need to give them confidence. You can have a fantastic life. All of you can live fruitfully. We are a little bit, we are not very sure because our education needs to be improved a bit to understand you. We will come up with an answer at a later point. That's all I can say.
Thanks for that very emotional appeal for the pediatric fraternity at large to approach these children with more sensitivity and sensibility. Thank you for those life lessons. We have three questions
Only
in the chat box.
one point. The future is also very good for type 1 diabetes with insulin pump, with this hybrid closed loop system. You have a sensor and a pump linked by a transmitter. When you have a low sugar, it can switch off. When you have a high sugar, it gives corrective doses. You can give your boluses and you sleep and wake up and eat as like everybody else. So the pumps have a lot of improvements coming in, and that would be actually a very doable thing in the
Game
future,
changer.
in the recent future.
Thank you. There's a question from Dr. Sukumar on whether there is a need to skip the thyroxine days or whether to draw the blood on an empty stomach with the presence of meal or taking the daily dose of prescribed thyroxine having the influence on the thyroid function test.
So usually we say that on the day when you're performing your thyroid test, you don't need to be fasting. There's no relation to food. But we do say that perform the test before you take the morning dose on that test. If the dose is taken already, then we usually ask for a gap of about 4 hours, and after which you can perform your thyroid function test. Because sometimes if you take the medicine and you perform the test, your free T4 or your T4 levels can come normal or may be high, and it may not really reflect what's been happening over the past 4 to 6 weeks.
I always ask them to do it before they take the medication for that day. Because if they have a normal T4 and free T4 on and before they take the tablet with the high TSH, it gives me a pointer towards poor compliance. But when you have taken your medicines and then taken your blood test, it will play with the results. It's very difficult to interpret the T4 and the free T4.
We have a question from Dr. Yashwini on once we have said that obesity can alter the TSH a wee bit. How long can we wait for TSH to settle down in obesity-induced hypothyroidism?
If the
TSH
child
is always
loses
less.
weight.
Please
Sorry, ma'am, go ahead. Go ahead.
Yeah. So if the TSH is up to 10 is acceptable in children, you don't look at the TSH at all. You wait for the weight to come down and don't bother about the TSH. If the TSH goes beyond 10, it's actually an evolving hypothyroidism. You will do a full-blown thyroid function test and start treatment. That has nothing to do with obesity.
And there's a question from Dr. Jayashi. In girls with short stature and features of hypothyroidism diagnosed and started on thyroxine, can we wait before we try to work them up for Turner's, or can they have coexistence? Is Turner's a risk factor for autoimmune hypothyroidism? Can we have two diseases? Is probably what she's asking. Should we do them tangentially or should we do them serially?
So usually, I mean, the guidelines would say that if you have an unexplained short stature in a girl, that's when you would want to look for Turner's. Most children where you have a girl with autoimmune hypothyroidism, I don't think we perform a karyotype to look for Turner in every such child, unless you're picking up certain stigmata. Because an isolated hypothyroidism as a manifestation of Turner syndrome would be quite rare. So from a practical point of view, you can wait, you can treat the child, and if you do pick up stigmata, that's when we would probably do a karyotype. I would, sir, if I may just add a practical point when we're talking about thyroid is today, we're also seeing in practice a lot of children coming with hypothyroidism where the family is using pink salt or rock salt. I don't know if that's the tradition in your state as well, but we have a lot of fads going on about using pink salt and rock salt. And that's a question that we now I have started asking every child because a lot of families are coming up with this history. And I think that is contributing to the increasing incidence of hypothyroidism as well.
So under our watch, you are saying that basically there is a dietary deficiency of iodine despite a national program for iodine deficiency control. That is worrisome. And you're sitting in a metro, and in Bombay, if it's happening, I'm shuddering to think of North Indian states where there's a much higher proportion of vegetarianism, and the entire sub-Gangetic belt, which has no access to seawater or probably even seafood. Other where they will get their iodine from is beyond my contribution. It's boggles the imagination. Anyway, thank you both panelists. I would be very, very um, what shall we say, guilty of not thanking you enough if I did not say these words, even though it's a formality. Both of you have been absolutely brilliant over the past 1.5 hours and have taken questions which are way below your professional competency levels. It's more like answering anxious parents rather than your colleagues in general pediatrics. We really thank you on behalf of IAP TNSC for taking the time out on a Sunday afternoon and educating us on the nuances. As we said, pediatric endocrinology is an ocean. You have probably had a couple of sips of water. Once again, on behalf of IPTNSC, I wholeheartedly thank, on behalf of the P4 team, Dr. Akila and Dr. Akanshka for an absolutely riveting 1.5 hours of practical, wisdomful, insightful pediatric endocrinology lessons. Thank you once again for sparing us your time. Any concluding remarks
Just
from
before
Dr. Rajendran, Dr. Tirumurugan, Dr. Singarvelu, sir?
Can I make one point? So there's a question on newborn screening for congenital adrenal hyperplasia. It's one of the most difficult diagnoses to make on newborn screening. It is not advised in the UK because you can have a lot of false positives and false negatives. So newborn screening is not the answer for diagnosis of congenital adrenal hyperplasia. Thank you.
Hello.
Dr.
Yes.
Thiru?
Thank you, Doctor. Thank you, Dr. Akila and Dr. Kansha, for a really enjoyable session. I think our team, IAPT NSC team, is really indebted to a wonderful session. Thank you very much, and I think we will have our next session in a month's time. Thank you. Good night.
Thank you very much. Thank you, Akanksha.
Good night.